This talk is about sleep medicine. These are the class objectives. You do not need to read them. We will use them to chart our talk. This talk will be conducted in a question and answer format. First question. Arousal promoting neurons are present in the A. Pons, B. Pons and midbrain, C. Pons, midbrain and posterior lateral hypothalamus, D. Pons, midbrain, posterior lateral hypothalamus, and basal forebrain. In this frame, I have listed 4 important regions involved in promoting arousal. An important arousal promoting group of neurons is in the caudal midbrain and rostral pons. These neurons form 2 groups named according to their location as LDT and PPT. LDT stands for laterodorsal tegmental nucleus. PPT stands for pedunculopontine tegmental nucleus. The neurotransmitters they produce is acetylcholine. During this talk, I will often refer to this nuclei, that is to the LDT and PPT neuronal group, as the caudal midbrain cholinergic group. Axons from these neurons reach the thalamus, the hypothalamus, the basal forebrain, and the prefrontal cortex. A second bunch of arousal promoting neurons, which I have chosen to lump into a large group constituted by different structures, is located at the upper pons. The reason I lump them together, creating a multigroup, is because that is the way that is done in a significant number of articles. In this frame, I have listed the 6 groups that constitute the multigroup by their initial letters. They are all monoaminergic neurons. I will refer to them as the pontine monoaminergic neurons in the rest of this talk. This multigroup includes the noradrenergic locus coeruleus, the glutaminergic parabrachial nucleus, the glutaminergic precoeruleus nucleus, the serotoninergic dorsal raphe nucleus, the dopaminergic periaqueductal gray matter, and the histaminergic tuberomammillary nucleus. The axons of these neurons have the same trajectory as those formed by the caudal midbrain cholinergic group. The third group of arousal promoting neurons are located in the posterior lateral hypothalamus. This group is constituted by neurons with different projections and neurotransmitters. One cluster of cells release orexin. Orexin is also called hypocretin. These orexin releasing neurons connect with neurons in the basal forebrain, in the caudal midbrain, in the cholinergic group, and in the pontine monoaminergic group. The other cluster of neurons in the posterior lateral thalamus with arousal promoting qualities are glutaminergic. These neurons make contact with neurons in the basal forebrain. The fourth group of arousal-promoting neurons is in the basal forebrain. These neurons use primary GABA as a neurotransmitter. So the answer to this question is D. Next question. Sleep promoting neurons are present in the dash A pons, B midbrain, C hypothalamus, D basal forebrain. In the hypothalamus, in the preoptic area, there is a group of neurons called the ventrolateral preoptic nucleus, VLPO for short. These neurons release GABA and galamine at their target organs. The arousing promoter target organs are the caudal midbrain cholinergic cell group and all the pontine monoaminergic group. Neurons in the pontine neuroaminergic group and the caudal midbrain cholinergic groups send axons back to the VLPO. It seems that the VLPO has a mutually inhibitory relationship with the arousal-promoting neurons of the caudal midbrain cholinergic neurons and the pontine monoaminergic neurons. This relation, that is the relation between the VLPO and the arousal-promoting brainstem system that we have just mentioned, according to some, is the basis for the switching between sleep and awake states. So the answer to this question is C. Next question. The molecular trigger that activates the ventrolateral preoptic area and initiates sleep onset have not been fully defined, but a substantial body of evidence points to extracellular dash as a candidate. A. Caffeine, B. Cortisol, C. Adenosine, D. Theophylline. This is a camera lucida drawing. The cluster of stars represent the area of the ventrolateral preoptic nucleus. Notice the relation of the optic chiasm and the third ventricle. I have now introduced a microphotograph of the area inside the magenta rectangle. The ventrolateral preoptic nucleus is indicated by the arrow. Adenosine is believed to be the molecular trigger that induces sleep. This nucleus also receives signal from the suprachiasmatic nucleus, the central circadian clock. So the answer to this question is C. Next question. The concept of flip-flop control of behavior state states that the activity of either arousal-producing or sleep-producing neurons dominate and suppress each other. A true, B false. So we have the arousal promoting system that we have previously described, and as you recall, it has 4 groups which are represented in this frame. If you have any question, just stop the video and look it over. We also have a sleep promoting system, which for our discussion is constituted by the ventrolateral preoptic nucleus. In this frame, I have introduced both systems in a balancing platform. This frame represents a moment where arousal promoting neurons and sleep promoting neurons, that is the two systems, are in balance, which would equate to being half asleep and half awake. This state lasts only a few seconds. Now, to your right, I have added a little face representing wakefulness. And below it, another one representing non-REM sleep. To your left, I have represented neuronal firing rate. During wakefulness, the arousal promoter group are very active. During sleep, that is non-REM sleep, the pre-optic region of the hypothalamus, that is the ventrolateral preoptic nucleus neurons, will be active, where the arousal promoting neurons would be rather quiet. So the answer to this question is A, true. Next question. Which of the following neuronal groups discharge during REM? A, sublaterodorsal nucleus, B, preceruleus region, C, medial parabrachial nucleus, D, all of the above. The effector nuclei involved in initiating, terminating, and maintaining REM sleep are in the brainstem. They include the sublaterodorsal nucleus, also referred to as the subceruleus area, the preceruleus region, the medial parabrachial nucleus, the lateral pontine tegmentum nucleus, and the ventrolateral periaqueductal gray matter. The laterodorsal nucleus, the preceruleus region, and the median parabrachial nucleus send connections to the lateral pontine tegmental nucleus and the ventrolateral periaqueductal gray matter. These connections are both ways. These connections are also inhibitory in both directions. During REM sleep, the sublaterodorsal nucleus, the preceruleus nucleus, and the medial parabrachial nucleus are very active. Thus, they are considered neurons with a REM on firing pattern and are called REM on neurons. So the answer to this question is D. Next question. Dash neurons inhibit entry into REM sleep during wakefulness by exciting neurons in the REM off population. A, VLPAG, D, orexin, C, VLPO, D, cholinergic. The sublaterodorsal nucleus, the preceruleus, and the medial parabrachial nucleus are very active during REM. The neurons in the lateral pontine tegmentum nucleus and the ventrolateral periaqueductal gray matter are very active during non-REM sleep. Orexin neurons, also called hypocretin neurons, connect with the REM off neurons. This connection is excitatory, so they activate the firing of the REM off neurons. The activated REM off neurons inhibit the REM on neurons and thus prevent or stop REM sleep. So the answer to this question is B. Next question. Which of the following parameters are needed for sleep staging in adults? A. Extraocular movements. B. Shin EMG. C. EEG. D. All of the above. Polysomnography is the most frequent ordered test in patients with sleep disorders. As you can see here, it consists of monitoring multiple parameters during sleep. These parameters are motion, monitored by video, and recording electrodes in the limbs, arm, and leg, breathing by recording from nose and mouth, chest and abdomen, shin muscle tone, eye movements, brain waves, heart rate, and oxygenation by finger sampling. A more restricted study just monitoring EEG, eye movements, and shin EMG is needed for sleep staging. This is an idealized sleep histogram. At this level, we have a wake time. At this level, we represent non-REM stage 1 and REM in magenta. This line represents non-REM stage 2. This line represents non-REM stage 3. Stage REM, as we previously mentioned, is represented at the same level as stage 1. In this case, by a magenta thick line. REM sleep recurs about every 90 minutes during sleep, and as you can see, their duration increases through the night. So the answer to this question is D. Next question. Which of the following should not occur during stage 2 non-REM sleep? A. Spindles. B. K complexes. C. Vertex sharp waves. D. Prominent amount of sleep delta waves. During polysomnogram for sleep staging, we monitor 3 parameters. We will first look at the EEG characteristic of each stage. You can see the typical EEG recording for each stage in this frame. The most characteristic EEG pattern during a wake occurs when the patient is relaxed with eyes closed. When relaxed with eyes closed, the prevalent EEG activity is alpha. Alpha activity consists of sinusoidal wave with a frequency of 8 to 12 Hz with occipital predominance. In stage 1, the activity becomes slower, mainly in the theta range, ranging from 7 to 3 cycles per second, and disorganized. This activity loses the sinusoidal quality it had in the wake relaxed patient with eyes closed. And occasionally, we find brief waves with 3 phases that interrupt the background activity. These are called vertex waves. During stage 2, the background activity remains about the same, but we find it interrupted by vertex wave, as we described in stage 1, but also, and more importantly, with fine spindles characterized by fusiform activity lasting more than 0.5 seconds. This activity is maximally represented over the vertex. During stage non-REM sleep 2, we also find K complexes. K complexes are well defined biphasic waves lasting 0.5 seconds or more, and usually maximally encountered in the frontal cortex. These later 2 elements brand the recording as stage 2. Stage non-REM 3 is characterized by delta waves occupying at least 20% of the background activity. Sleep delta waves are large, that is, they are more or equal to 75 microvolts and slow in the range of 0.5 to 3 Hz. During REM, the background activity is fast in the beta range, that is more than 12 cycles per second, and at times this activity is interrupted by theta sawtooth waves. This frame shows the location where different sleep elements are more prominent. Stop the video, get a sheet of paper, draw a head, then place in it the location of the different elements. Before leaving the subject of brainwave captured during polysomnography, I want you to recall that earlier in this talk we mentioned 4 structures that were very important in the generation and control of sleep. These structures are listed in this frame. The EEG changes seen during sleep depend to a great extent to the interaction of the thalamus and the cerebral cortex. So the answer to this question is D. Next question. Slow rolling eye movements are usually present in sleep stage A, N1, B, N2, C, N3, D, REM. In this frame, you can see eye movements recording from different sleep stages. While awake, while reading or looking from side to side, eye movements are crisp. This is recorded by eye electrodes as sharp waves. When the patient closes the eyes and relaxes, these sharp waves disappear and no eye movements are recorded. As the patient goes into stage 1 sleep, slow eye movements appear. You can see by the undulating nature of the record here marked. During sleep stage 2, no eye movements are usually present. During stage 3 non-REM, no eye movements are present. During stage REM, there are rapid eye movements. So the answer to this question is A. Next question. Which of the following changes occur during REM sleep? A. Extraocular muscle contraction. B. Middle ear muscle contraction. C. Increased brain acetylcholine content. D. All of the above. Here I have depicted REM-on neurons as a simple green dot. The neurons in one of the REM-on nuclei, the sublaterodorsal nucleus, also called the subceruleus area, hyperpolarizes lower motor neurons, rendering them unexcitable, thus producing muscle hypotonia in most muscles except the diaphragm, the extraocular muscles, and the middle ear muscles. In addition, REM-on neurons activation is associated with increased brain oxygenation and acetylcholine content, as well as significant changes in pulse and blood pressure in pineal and clitoral tumescence. So the answer to this question is D. Next question. Chin EMG is lowest during REM. A true, B false. The chin EMG recording during polysomnography reflects the changes of most of the muscles that occur during REM. During awake, the chin EMG is high. Chin EMG tone drops during stage 1, more so during stage 2, and even more so during stage 3. But its lowest occurs during REM. So the answer to this question is true, A. Next question. In young adults, most of the sleep time is occupied by sleep stage A, non-REM 1, B, non-REM 2, C, non-REM 3, D. REM. This frame shows the percentage of sleep in the different stages in a young adult. N1 represents 5%, N2 45%, N3 25%, REM 25% too. So the answer to this question is B. Next question. When compared with young adults, elderly adult sleep studies usually show an increase in REM and N3 stages. A true, B false. These two sleep histograms are represented in a slightly different fashion from the one I showed you before. Here, stage 1 and REM stage are represented at different levels. In older adults, as compared to young adults, the sleep is more fragmented, more awake time after falling asleep, REM sleep is down, and so is non-REM stage 3. So the answer to this question is B. Next question. Sleep histogram changes in depressions are A. Increased REM sleep time, D. Decreased REM sleep latency, C. Decreased N3 sleep, D. All of the above. These sleep histograms show the difference between normal, here labeled control, and depressed patients. These changes are decreased REM latency, increased awakening from sleep, increased REM sleep, decreased stage 3, and terminal insomnia. This means waking up early in the morning and not being able to go back to sleep. So the answer to this question is D. Next question. The mechanism regulating delta wave production and DASH secretion are closely coupled. A. Adenocorticotropin hormone, B. Growth hormone, C. Cortisol, D. Melatonin. Hormone secretion and sleep-awake cycle have three types of relations. Relation number 1. Some hormones are little influenced by sleep versus wakefulness. They are nevertheless influenced by circadian rhythm. Circadian rhythm is related to day and night, light and darkness. The term circadian means circa for about and dian for 1 day. Among these hormones, we have cortisol. The reason we say sleep does not influence and circadian rhythm influences cortisol secretion is based on studies demonstrating no hormonal secretion variation when sleep time has been modified. In this frame, you can see two curves reflecting the amount of blood cortisol in relation to time. The green line represents the cortisol blood level curve when sleep time starts at 11 p.m. and ends at 7 a.m. The brown line represents the cortisol levels in individuals when the sleep time occurs between 7 a.m. and 3 p.m. Both the green and the brown lines are not significantly modified by the change in sleep time, as you can see. In addition to cortisol, in this group we have ACTH, norepinephrine, and melatonin. Notice how different melatonin secretion curve is from all others. Think of melatonin as the hormone of the night. The other three are hormones of the day. Group 2 is populated by hormones that are strongly influenced by sleep, such as prolactin, the aqua line reflects high prolactin level during sleep when sleep was during the night. The magenta line represents high prolactin levels during sleep when sleep occurred during the day. This is the result of a similar study, but these researchers in this study included sleep histograms. The sleep histogram of the first test reflecting nighttime sleeping coincided with high levels of prolactin during sleep, the peak occurring randomly during sleep. The sleep histogram of the second study, reflecting daytime sleeping, showed prolactin increased during sleep, and again, the peak secretion were not related to specific sleep stages. Also, in this group, we have thyroid stimulating hormone, TSH, increases occur during sleep, regardless if sleep was at night or during daytime. Group 3 consists of hormones not only affected by sleep, but by a particular sleep stage. In this group, we have growth hormone. As you can see, growth hormone during nighttime sleep increased during the early hours of sleep when non-REM sleep stage 3 is prevalent, and so occurred during daytime sleep. So the answer to this question is B. Next question. The pathway that influences the pineal gland to secrete melatonin involves the A. Otic ganglion, B. Geniculate ganglion, C. Sphenopalatine ganglion, D. Superior cervical ganglion. Here we have a sagittal cut of the brain. The aqueous rectangle is in the area of the pineal gland. I have now introduced a histological specimen of the pineal gland. The primary cells in the pineal gland are the pinealocytes. The pinealocytes secrete melatonin, which goes into the bloodstream and to the CSF. Melatonin, the hormone of the night, goes up as it gets darker. And when it reaches a certain level, it induces sleep. We know that because if we give people unable to sleep melatonin, they do so in about 30 to 45 minutes after they take it. Why? To explain this, we must go to the rat. This is the brain of a rat, at least a representation of one. I have just pointed to the pineal gland. The pineal gland is large in rats compared to men. I also will point out to you the retino-hypothalamic tract, which I have just indicated. The suprachiasmatic nucleus, which I am now indicating, and the paraventricular nucleus. In rat, there are 4 pathways to the pineal gland. Pathway number 1 starts in the retino-hypothalamic tract that is in the retina, and it reaches the suprachiasmatic nucleus. From the suprachiasmatic nucleus, it connects with the paraventricular nucleus. And from the paraventricular nucleus, it reaches the pineal gland. Pathway number 2. This pathway involves the sympathetic neurons in the intermediolateral nucleus of the thoracic cervical spinal cord. This pathway has a similar trajectory as the previously described pathway up until the paraventricular nucleus. From there, through the dorsal and ventral tracts, fibers reach the intermediolateral nucleus of the thoracic spinal cord, and from this nucleus, fibers travel to the superior cervical ganglion. From the superior cervical ganglion, then fibers travel by the coronarian nerve to the pineal gland. Pathway number 3 probably starts in the hypothalamus, but it has only been mapped from the superior salivary nucleus. From this nucleus, nerves make contact with two ganglia, the sphenopalatine ganglion and the otic ganglion. Fibers from these ganglia go back into the skull to reach the pineal gland, providing parasympathetic innervation to the gland. Pathway number 4. This pathway is sensorial, hence it ends in the spinal nucleus of the trigeminal nerve. It originates in the pineal gland. It consists of axons from the neurons that are in the trigeminal ganglion, as shown in this frame. So this is for the rat. What about humans? As we know, pinealocytes secrete melatonin, influenced by darkness. The information regarding darkness travels in the pathway just introduced. The neural control of pineal melatonin synthesis starts with the retinohypothalamic tract. This tract reaches the suprachiasmatic nucleus. From there, fibers travel to the paraventricular nucleus. From the paraventricular nucleus, fibers travel to the sympathetic neuron housed in the intermediolateral column of the cervicothoracic spine. From here, they go to the superior cervical ganglion. From there, they travel with the jugular vein by a set of nerves called coronarian nerves. These nerves secrete norepinephrine at the pineal gland and initiate the process of melatonin secretion. So the answer to this question is D. Next question. Night terrors tend to occur during a sleep stage: A. Non-REM 1, B. Non-REM 2, C. Non-REM 3, D. REM sleep. This is a classification of sleep disorders most widely used. Stop the video and read it. Among them, you have parasomnias. Parasomnias are abnormal behavioral and autonomic events that occur during sleep. They are usually classified according to the sleep stage when they occur. In the next frame, I will break down the classification. During the transition from awake to sleep, we find terrifying hypnagogic hallucination. The term hypnagogic means when going to sleep. We also find hypnic jerks and rhythmic movement disorders. During REM sleep, we find nightmares, sleep paralysis, hypnopompic hallucination. Hypnopompic means as you get up, painful erections, and REM sleep behavioral disorders. During non-REM stage 3, we find confusional arousals, sleepwalking, sleep or night terrors, and sleep-related eating disorders. Usually during stage N2, we find sleep panic attacks, sleep talking, and bruxism. Parasomnia with non-stage preference include violent behavior in sleep, nocturnal leg cramps, and nocturnal enuresis. Nocturnal enuresis. In this article, the best review on the subject I have been able to find, the authors found that although most common during the first half of the night, enuresis were not linked to any specific sleep stage. So the answer to this question is C. Next question. Nightmares occur during the second half of the night. A true, B false. This frame shows a night sleep histogram and the proportion of time spent in each stage by a young adult. Notice that most of REM sleep occurs in the last half of the night, that is, of the sleep period. During REM sleep, most frequent parasomnias are, as we previously mentioned, nightmares and REM sleep behavioral disorders. During stage 2, the longest stage, bruxism tends to occur. During stage non-REM sleep 3, which tends to occur during the first half of the night sleep, we find sleepwalking, night terrors, and bed wetting. So the answer to this question is true, A. Next question. Daytime sleepiness can be evaluated by conducting multiple sleep latency test and maintenance of wakefulness test. A true, B false. Daytime sleepiness can be evaluated using multiple sleep latency test and the maintenance of wakefulness test. Multiple sleep latency test is done to determine the number of trials when REM sleep, called sleep onset REM, and the mean sleep latency. A polysomnogram is done the night before in most cases. Then the patient is given 4 20-minute opportunities to nap and to add one more, the fifth, if one of the first 4 trials have shown a sleep onset REM sleep and the previously polysomnogram did not show a sleep onset REM. The first trial should be done about 2 hours after getting up from bed in the morning. Other trials should be carried out at about 2 hours after the initiation of the prior nap. The test is considered abnormal if 2 or more REM onset sleep are present. As you can see in this frame, this is how a sleep onset REM looks like. The patient is initially awake. There are no eye movements. Shin EMG is high, and the EEG shows alpha activity. In the second half of the tracing, rapid eye movements appear. Shin EMG loses tone, and the EEG shows theta activity. MSLT is also abnormal if the mean sleep latency, that is the time it takes a person to fall asleep, is 8 minutes or less. The maintenance of wakefulness test measures the voluntary ability to stay awake under conditions that favor falling asleep. The organization of the procedure is the same as MSLT, except that the trials last for 40 minutes and the patient sits upright and not lays down as for the MSLT. A total of 97.5% of normal sleepers stay awake for an average of 8 minutes or more during MWT. So the answer to this question is True. Next question. Narcolepsy is characterized by all of the following except A. Excessive sleepiness, B. Cataplexy, C. Obstructive apnea, D. Hypnagogic hallucinations, E. Sleep paralysis. Here you can see the classification of the sleep disorders that I have shown you before. Among the major headings, we have hypersomnia of central origin. By definition, in order to diagnose this group of disorders, other causes of hypersomnia must be ruled out. Narcolepsy is in this group of hypersomnia of central origin. The clinical manifestations of narcolepsy include excessive daytime sleepiness leading to 3 or more unplanned naps per week per 3 or more months, cataplexy, which is loss of all muscle tone except for diaphragm and middle ear following strong emotions such as laughing, hypnagogic hallucinations, sleep paralysis. Narcolepsy is due to decreased orexin, also named hypocretin, as you know. In addition to hypersomnia of central origins, another condition producing daytime sleepiness included in this classification of a sleep disorder is sleep-related breathing disorders. The most representative condition in this group is obstructive sleep apnea. Obstructive sleep apnea is characterized by lack of nasal and mouth breathing for more than 10 seconds, associated with respiratory movement of the chest and abdomen, at times paradoxical, as indicated by the red arrow. Often, the apneas are associated with snoring. This condition is often seen in obese adults with normal daytime oxygenation, but often with hypoxemia during the apneic episode. In this frame, you can see the mean latency of MSLT of patients with narcolepsy, obstructive apnea, and in control. As you can see, the lowest mean sleep latency occurs in patients with narcolepsy, and then in patients with obstructive apnea. Normally, during sleep, long abbreviation is good. During obstructive apnea in adult, it is not, neither it is in children. Obstructive apnea in adult is due to excess parapharyngeal tissue and tongue atonia. Obstructive apnea in children is due to adenotonsillar hyperplasia. The treatment is diet to lose weight, continuous positive airway pressure, oral devices, and surgical procedures when warranted. So the answer to this question is C. Next question. Polysomnogram should be the first test done in patients with insomnia. A true, B false. Here you can see the classification of sleep disorders again. Insomnia is characterized by difficulty in either initiating sleep, maintaining sleep continuity, or poor sleep quality. This is the classification of insomnia. Most of the insomnias are treated by psychiatrists or sleep medicine specialists. Stop the presentation and read them so you can get an idea of some of the many conditions capable of producing insomnia. The role of the general practitioner is to make sure no medical condition is producing the insomnia. The initial laboratory workup in an adult, usually done in patients with a negative history and physical examination, should include thyroid function test, glycosylated hemoglobin, complete blood count, serum iron studies, liver function test, and renal function test. Polysomnogram should not be the first test ordered in patients with insomnia. It is important to stress that polysomnogram should be done if no cause is found after the initial workup, especially if sleep-related breathing disorders or sleep-related movement disorder are being considered. Prominent among these, we have restless leg syndrome. Patients with restless leg syndrome have an urge to move, especially in their legs, and do so at all times of the day, especially at sleeping time, to the point that the most frequent complaint that drives these patients to see a doctor is insomnia. The urge to move the legs is relieved by moving the legs, but moving the legs keeps the patient awake. Restless leg syndrome is seen in association with metabolic diseases, such as kidney disease, and a search for metabolic conditions should always be considered in patients with restless leg syndrome. In some cases, iron deficiency is the cause, and treatment with iron improves sleep. So the answer to this question is false. Thank you very much for your attention.